Great, thank you. The topic for today is patient-driven model of therapy, facilitating success within dementia levels. Before we get started, I just want to let you all know that your lines will be muted. If you have any comments or questions, please write it in the chat box and we will save time at the very end to address any questions that you have. Something really important that you need to know is if you are sharing a screen with someone else, please put in the chat box your name and email address. Otherwise, we don't know you're on the call, and if you want your CEU credits, we'll need to have your name and email address in the chat box. This is an hour-long presentation, and there will be questions at the very end if you have any. If you have any questions, please put them in the chat box. My name is Rebecca Olson. I'm an occupational therapist, and I'm also a clinical practice specialist for Aegis. I have been with Aegis for over 26 years, and I have been working in the dementia field for most of those years, if not more, for about 30 years. And dementia is one of my clinical passions. And then I will introduce Barb White.
Hello, everyone. My name is Barbara White. I'm a physical therapist, and I've been with Aegis Therapies for just over 15 years. I've been practicing for 21 years, and the majority of my experience has been in long-term care, but I've also helped out with home health, outpatient, and special needs pediatric. So I just want to quickly reference back to the title of the course, and I just want to bring everyone's attention to the words patient-driven. We're going to be talking a lot about really getting to know your patients and letting that knowledge guide your treatment. So with that said, the first objective of this course is to emphasize the value of determining patient-centered needs in their cognitive levels. It's important that we first get to know our patients so we can determine what's important and has meaning to them, so we can better determine their needs. It's also important that we establish a cognitive level so we can provide appropriate treatment and interventions so we're successful in meeting their needs. The second objective is to identify appropriate assessments to build on. The third is to discuss key indicators of early, middle, and late stages of dementia. And the fourth and final objective is to integrate treatment strategies catered to the person-centered needs of the residents. The value of knowing your patient. So by knowing your patient, you'll be able to define what has meaning to your patient, and you'll be able to define the person. It's important that we recognize that each person is unique and has different life experiences, routines, and habits. Knowledge of your patient's history can help you build the most effective program and improve the patient's quality of life. So be sure to utilize family and friends in addition to patient interviews to gain as much knowledge about your patient's likes and dislikes as possible. Knowing our patients means determining their baselines, including memory, communication, behaviors, ADLs, and mobility. This will allow for increased ease of developing appropriate goals and programs for your patients. Knowing our patient's cognitive level will help us establish appropriate expectations of performance, and let us consider complicating factors such as perceptual, motor, and communication impairments. As we identify and establish patterns and routines for our patients, we can avoid outbursts, more effectively manage behaviors without medications, blend meaningful activities with their cognitive level, allowing them to function at their highest level, and ultimately slow the progression of their chronic disease process. And now Becky is going to review some of the assessments.
All right, this is one of my favorite things. Assessments are key. You have to know your baseline, you have to know your patient, and there's so many different assessments out there, but I just want to share some that are easy, accessible, short, quick. Time is of essence, and so one of the first things I wanted to share is the leather lacing. And again, this is very brief. It's an approximate level. It uses the Allen levels. It comes with a book, and it has 3 different types of stitches on the leather. Instructions are included, and you do have to read the instructions. It's very specific, and it also will allow you to determine an approximate level of the patient. Another assessment that is one of my favorite, I love this. This is a kit that I often put together. It's called the Cognitive Performance Test. This is one of my favorites because it's functional, it is standard, it's standardized, it gives you a very detailed and specific cognitive level with even the cognitive mode. So it has 6 levels, 52 modes, and there are 7 subtests. So the subtests consist of the med box, which is very functional, wash, shop, phone, travel, toast, and dress. You take an average of at least 5 of these and you get a cognitive level. You can repeat this assessment as well. Another assessment that highly correlates to that is the Allen Diagnostic Module, or sometimes it's called the ADM. Sometimes it's called the placemat assessment. It uses placemats or different crafts that you use, and you have them follow a design. And the more they do, the higher the points they get. So from there, you determine a cognitive level. This is also another one. It's a 2-page. It's called the Modified Interest Checklist. It is online. All 3 of these you can pull from online. Any discipline can provide it, but I really like this because it really allows you to find out what the patient is interested in. So many times we want to fit their world into ours. So we want to fit into their world. So a lot of times patients with dementia do better with yes, no questions. So if I came with an open-ended question that says, what do you like to do? They're not going to be able to really tell you, wow, nothing. I like to watch TV or I like to sleep. But if I ask, do you like to do bird watching? Then they could respond yes, no. So it really allows you to find interest that's specific to them. It's a way to get to know your patient. If your patient is not able to verbalize yes or no, or is unable to communicate, you can use family members to gather this information as well. Another one of my favorite is the routine task inventory. You can also get this one online. It has 4 categories that you rate: physical scale, which is your ADLs, your community scale, which is more of your IADLs or your shopping, medication, some of those tasks. It also has communication scale, so that's helpful to know for speech or even how they communicate with you. Then the 4th is the work readiness scale. Now you'll see 3 columns here. There's an S column, which is self-rating. They can rate themselves. C is the caregiver rating, and T is the therapy rating. And I really like this because I don't know about you, but you have those patients that as soon as you pull out any kind of cognitive assessment, they freeze up or they get agitated, and I don't want to do that. That's stupid. So this way, you could just communicate with them. You can gather an approximate level. You can observe them doing any kind of basic ADLs. You can ask family members what they're able to do. This is really nice because you can really get an assessment or an approximate level and they don't even know you're doing it. This has been really helpful to me, even for people that don't speak my language, or I don't speak their language, I should say. I can just observe them and I can get an approximate level. So that's the RTI, or the routine task inventory. This next one is also for any discipline. And I love this one because it's really a nice way to find out what your patient really likes to do or doesn't like to do. It's called My Way. It's online. You can pull it off. It's free. You can print it out. But I really like it because it gives you very specific things like your sequence of your showers. Do you like baths, showers, or do you like mornings or afternoons? Do you like to brush your teeth in the shower? Do you like the door shut when you go to the bathroom? There's 2 pages of this, and you can have your caregiver fill it out. You can have the patient. You can have a discussion with your patient, but it really guides you through a series of questions. And this is what this is all about. It's a patient-driven model. It is what is best for your patient. And you and I, we all know that if we try to do something out of their patterns or out of their structure, you're going to get some negative reactions. You might get some agitation. You might get some, I hate to use the word behaviors, but any kind of response that may be not so pleasant. So this really avoids a lot of that confusion and agitation. So that's called My Way. Now, this is another one that was developed by Aegis. It is not online, but I really wanted to put it in here because it's an excellent way of working with the lower or the severe cognitively impaired. It's called the sensory motor assessment, or SMA. It really primarily focuses on the sensory response. So even if you have someone that's so low level that maybe really the only way to know that they're responding to any kind of stimuli is an increased blood pressure or an increased heart rate, or maybe their respirations increase. It also guides you as to what is the next progression of the stimuli that should be used for patients. So I really, really like this because it has dates and it shows progression, and it is objective, and that's really what this is all about, objective data. So that was called the sensory motor assessment. Now, this last one that I'm going to mention, I know there's many, many others, but I'm trying to do a shortened version for you. This is just your interview with families and caregivers. And who knows your patients better than daughters, sons, husbands, CNAs? They can tell you exactly what time they like to get up, when they last had a bowel movement, what causes agitation. They really know your patient better than anyone. And so don't forget that. Don't forget to really gather a lot of information. They have a wealth of information. Don't forget that. Next, we're going to start going into some of the stages. Now, the stages, I'm going to just quickly introduce you first. The early stage, of course, are those stages that really, they kind of blend in, and you know something's not quite right, but you haven't got it figured out yet. A little bit of forgetfulness, maybe lose a track of time. But the thing that really starts you thinking is they get lost in familiar places, or they've driven to a place that they got lost all of a sudden. So you'll start to see some early signs of it, but it can go unnoticed and covered up quite well. Your middle stages now, that's when you definitely know that something is wrong. They need help with ADLs now. They're wandering. They don't really have a focus. They forget people's names, that maybe even their husband's name or their children's names. And you will notice that they start to speak in kind of short phrases. Now, the late stages, are definitely, they're unaware of time and place. They don't recognize relatives. They start to even lose their ability to ambulate, or they get real fearful of transitional movements. And they are the ones that you try to stand up and it's like, no, 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 just let me do it. But then they never do it. So that's real typical of what you see in the late stages. I love these images here. This is a picture of what the early stage looks like. So you will see this pink area around here. That is their visual awareness, not their visual acuity, their visual awareness. It's what they're conscious of. So you see a lot of signs in their rooms where call, don't fall, but it's clear across the room. Well, don't forget their visual awareness is only around their body. It's only several feet within their body space. So some of the things you will often hear them say is this right? Or what's next? Or, I've done this before, but then they make the same mistake again, over and over. This is often, you will see, they look pretty good here. You know, this man here, he's got a nice shirt on. He's got nice pants. His shoes are tied. We have a little bed head going on here. We have the hair, you know, he looks really good in the front, but he just got up from a nap. And so we've got the bed head going on. We see a lot of ladies, like, you know, they will have beautiful makeup on. They'll look gorgeous, but then they have the bed head going on. These people also don't really attend to what they don't see. And so brushing teeth might not be so important. They might have odor sometimes just because they're just not aware of it. So for the most part, they look pretty good. And I would say that these people are people that are really good in like an assisted living, where we don't really want them driving. They shouldn't be doing their medications, but you know, they could get dressed and they could go to eat. They could do those things. So those are your early stages. Now, as I promised, we want to talk about some treatment ideas. I mean, that's what you're here for. You know, what do I do with these people and how do I deliver a patient-driven model to the early stages of dementia? So what Barb and I did is we made two columns, things that you want to consider and maybe some treatment ideas for you. So this is where we're going to spend the bulk of our time. So remember, these are your early stages. These are your people that are they're still living at home, but you know what? They just probably are struggling. They're usually struggling at home. So they're successful in the ALF. And like I said, they're pretty good with their basic self-cares. We should probably unplug their stove. We should get some supervision going on with their medications. And remember, these people, we said earlier, they can recognize an error, but they can't correct it. So I can administer the CPT test, the cognitive performance test, and they will say, oh, Becky, I've done this before, but yet they will still make the same mistake. Very big in high falls risk. I had one lady not too long ago that was in high heels. She was 92 years old, fell off the ladder in her kitchen because she was wiping off the kitchen and the refrigerator in her kitchen, and the phone rang. So just high falls risk, just not really able to do two things at one time. Difficulty with change. Now this is a big one. Now you've all heard the statement, oh, if I was at home, I would do just fine. I know you've all heard this, and this is probably one of the most common things that I hear from the from the patients is, I do just fine at home. Just let me go home. But they have really difficulty with change. Oh, I can't do this microwave because mine is different at home. Or my bathtub is not set up like this. I could do just fine if it was set up like this at home. Change is difficulty. And that's why when we were talking about that my way assessment is so important, because they really have a hard time with change. They really do. They're very closed-minded. Nope, not gonna do that. Nope, that's not the way I do things. They usually use the phone, but very minimally. It's maybe just to answer it if someone calls. They might be able to call out, but they probably have 10 messages in their phone. Yeah, I know you know what I'm talking about. They accuse other people of stealing things because they can't remember where they put it. They usually have difficulty with relationships. They are often accusatory and difficulty to reason with. Difficulty with generalization of skills. That's what I mean by they can do their microwave at home, but they can't do it in your therapy gym. It's not the same. Okay, we talked about the other ones already, awareness of 3 to 4 feet around them. They could learn new material with repetition, and that's important, because the higher level 4s, they could learn precautions and how to use adaptive equipment, but your lower level 4s really don't, they struggle with any new material. So if they haven't used it before, then don't try to teach them something new. And again, don't forget, your treatment is not going to be teaching the patient, well, you could be teaching them some new skills, but you're going to be focusing on restoration and compensation for treatment. So now let's hop into those treatment ideas, okay? So what can we do for early stages? So whether you're PT, OT, or speech, a lot of things are blended. So I don't want to say that one is for speech, one is for PT, one is for OT, because they all are, you all get intertwined with each other's disciplines. But you might see them using a phone or asking for a phone number or trying to make a phone call to their brother. So those are some good goals. You could use that as a goal. You might even need to set up some list of phone numbers at home if they're discharging back home. Calendars or journals are key, especially when they start accusing family members of not coming in to see them. This might really help. Calendars to help remind them of what appointments of therapy, maybe who's come to visit them, when therapy comes. All those things are really important because they are forgetful, but they don't want you to know it. Light meal prep is really important. Walker safety techniques, gathering, how are they going to water their plants? How are they going to open up the curtains? How are they going to turn on the lights? How are they going to carry their cup of coffee if they have a walker? All those things are important goals to think about. Memory books are really good to start, especially because we know that when they start getting to the lower levels of dementia, they're going to have trouble remembering names. So putting together memory books, scrapbooks, photos with names on it is really important. So if you're a speech therapist, man, that is a wonderful thing to do. Turn taking. These people really struggle with taking turns, or they're really often sore losers. So just really helping them to manage any kind of conflict is really good. Setting up list of ADLs to complete in the morning, setting it by their mirror, because don't forget, you need to brush your teeth and you need to to wash your peri area, wash your armpits, those kind of things, because otherwise, if they don't see it, they don't do it. This might be where you start need to introduce the urinals for men. They're used to standing, and now their balance is starting to get a little impaired. So you might want to start introducing urinals if they've not used urinals. Risk of falls to the bathroom at night is very high, and so this is even more important. Medication regime. You know, this is one of the most common reasons that people return to the hospital is medication errors. So really making sure that your patients know what medications, what to look for. I've even had patients that every day they got on the scale because they had edema. They would get on a scale every day and write down their weight. And if it was above a certain weight, they had to call their daughter or they had to call the doctor. So that was a routine that they had to do every day. Do they know the side effects and when to call the doctor? Do they know what different pills look like? Do they know the new medications? All right, so let's think about exercises too. Exercises, limit it to 5 to 10 repetitions because their attention span is much shorter. They will lose interest. Make sure that your exercises show pictures. If you just have words, they're not going to follow it. UPT's balance is really, really important. So really put them through the drills of higher level balance activities because they are very high risk for falls. Home assessments are really important because if they're going home, are they going to be going downstairs? Do we need to block off the stairs some way? Because we know that as soon as we turn our back, they're going to be going down to the basement to get something or to the lower level. So really making sure that the environment is set up, the beds are appropriate, they can get up and down from the furniture, they can reach the lights, there are night lights set up. There's 101 things to really look at when you do a home assessment, particularly hoarding. Early stages, you might start to see clutter develop. So really paying attention to what's on the floor, stacks of newspapers, pets. Pets is another one. Oof, pets. So many falls are from pets getting underneath their feet. So there really needs to be a routine of, okay, when I'm walking, then I need to chain up or I need to leash the dog when I'm getting up to walk to the bathroom. So it needs to be some planning around that. All right, now we are going to go into the middle stages. Middle stages, you definitely know that something is going amiss here, right? So you look at this person here and you see this pink area here, okay? So you've got this pink area and that is their awareness. So they are very, can I say, very focused on just what their body is doing. Very, very almost selfish because they do not see beyond where their body is. So let's look at this gentleman here. Now, he's got, he looks a little disheveled. You know, he can get buttons together. He can get a shirt on. He's got one sleeve short, one long. He's got pants that are hanging loose. We've got different colored socks on. Hey, this is your classic new look, right? All right, so these patients now, you definitely have some issues going on with them to complete self-cares. They start to need some help. So think of this as like a 3 or 4 year old that really wants to do it themselves. You know, they want to get their pants on, they want to get their shoes on, but they're on the wrong feet. This is exactly what the middle stages are like. So these people, for some reason, have a lot of cologne or too much cologne. They're big wanderers. They wander, 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 wander. They get into things. They rummage. They don't really know what they're looking for. So if they're going through these drawers, what are you looking for, Mary? I don't know. So I think of the middle stage as your wanderers. You really don't have a goal in mind. So some things to consider now when you're doing therapy is it takes them about 3 to 4 times longer to process the information. So what does that mean? Well, that means that just use one-step commands. If you throw 3 or 4 steps at them, you've lost them. Speak in short phrases. Use a lot of tactile cues like stand up, because the more you talk, the less they hear. I don't know if that makes any sense to you or not, but I get it. Too much verbalization, just they shut down. It's overstimulation. So you want to really avoid overstimulation in the middle stages. Overstimulation is really difficult. So think of your patients in the dining room. They got the TV going, they got people chattering, they got the CNAs over delivering meals, they got staff yelling back and forth to each other or residents talking to each other. That's an overstimulating environment. So be aware of that. Also be aware that they only have about a 14-inch awareness at eye level. So what does that mean? Well, that means that, you know, if their walker isn't within their environment of a foot and a half, 14 inches, that's all they're going to see. So you might label their walker with some fancy design or something, but they're not going to see anything across the room. They're not going to see a call light or anything unless it's within 14 inches of their awareness. One thing that I will say with these middle stages now is that you can learn a familiar destination such as a bathroom. So the middle stage, let's say they're new to your facility, you can do repetitive to and from the bathroom or to the dining room. It usually takes about 3 weeks for them to get it, but if you practice that, you can learn familiar destinations. So just takes a little bit longer. Your focus on therapy will be procedural memory. And your focus will be primarily not on getting the patient better, but teaching caregivers how to approach the patient. Now, this is really going to be important because you're not going to teach the patient new things. You're not going to be changing the way they do things. You have to enter into their world. And so really, we have to train caregivers on how to do the correct approach for them. All right, so let's get into some treatment ideas. So I was at a facility where we had like a reminiscing room. It was just a very, very small room. It was about the size of a large bathroom, I would say. But we had belts, we had purses, we had jewelry, we had toolboxes, we had books, reminiscing things. It was a wonderful room for the middle stages, because remember, these people like to wander and they like to rummage. It doesn't hurt anything. They're you know, if they walk off with a purse, it's not going to hurt. You know, it's just there that we collected them from garage sales or something. But reminiscing boxes that are very specific for particular patients work really good. Make sure that you know My Way for them. Information from your caregivers is going to be key because you need to know what they like to do for their routine. They are not going to be happy if you change up their routine. Something else for you OTs, if you want to place their clothing in a row, that will help them sequence. Make sure you don't give too many choices. Opening up the closet and it's got clothes packed top to bottom. What do you want to wear today? No, that's overstimulating. Really giving them two choices, like, do you want to wear this blue outfit or do you want to wear this red outfit today? Two choices. Sorting is a really good activity for them if they're really agitated and they just need to calm down. I was on Pinterest the other day and they had someone sorting M&Ms. I thought that was kind of interesting. But you could have them sorting cards, silverware, colored paper, whatever you might do. But they really respond well to sorting, cutting out coupons, that kind of thing, just to kind of calm them down. Folding baby clothes. I find that a lot of my ladies love just folding baby clothes, matching baby socks. It is a way that I can strategically put the basket of clothes on the floor while they're standing, and then they would reach down in the basket, bring it up, fold it, and then reach it to a pile. It's a dynamic balance activity. It's a reaching down and reaching up. Clothesline hanging, putting dishes away, setting the table. I've seen a lot of therapy departments that have a clothesline from one section to another section and clothespins on it. They hang up shirts or something. It's a lot of reaching, a lot of balance, functional things for them. These people are not going to like to do too many exercises. Obstacle courses are really good because they don't see much below their knees. And so really cueing them to look below their knees is critical. Environmental modifications. If they're not going to use their walker to get from one place to another, maybe we need to set up furniture so that they can furniture walk to the bathroom. Different ideas that you can be creative with environmental modifications. Intent strengthening, repetitions, sit to stand drills are really good, especially on different services. You can take them to the day room and have them practice up and down on different services. Couches, chairs, chairs without arms. Those are really good activities to do for someone in the middle stage. I must say too, any kind of physical release is really important. Exercise, biking, FMPs for any kind of exercises are really good for these middle stages. They have a lot of untapped energy that needs to go out. All right, now I'm going to switch it over to Barb. I'm going to let her share her ideas with the late stage.
Thank you, Becky. So late stage dementia patients, these are some of my favorite patients to treat. That wasn't always the case. When I first started treating dementia patients, I was very apprehensive about it and I was very uncomfortable with it. But as I just kind of jumped in and started doing it, they really surprised me. I really learned a lot from them. And as I started to have more and more success, I really enjoyed treating them. So hopefully, if there are any of you out there that are apprehensive, that this presentation that we're doing is going to give you the confidence to kind of jump in, and hopefully you'll start having some success stories of your own. So as you look at this slide, there's just a few things I want to bring your attention to. So I like to use this as a quick reference in the clinic, especially when I'm supervising PTAs, and they struggle a lot with these late stage dementia patients as well. So first, the patient's field of conscious awareness is very limited in the late stage dementia. They don't notice barriers below their knees. So this would certainly be something to consider when performing gait training or even wheelchair mobility. You know, they're going to be bumping into things. So when you're doing those activities with them, you're not trying to train them to avoid those things. You need to be modifying their environment so they're not bumping into things. You see the spoon in the patient's hand, so they can grasp and hold objects, and they may be able to self-feed with the spoon or finger foods. These patients, they are able to overcome gravity, so they can sit up in a chair, and many times they can sit up in a chair with not a whole lot of support. So a lot of them will show you that they actually have pretty good core stabilization and sitting balance. They can stand and walk with assistance, but be careful because they will spontaneously stand. They do very well with directed walking. You can see the words there on that slide that say follow me. They also do well with walking towards identified locations such as doors or toilets. These patients are followers, and so you're going to be directing them. They're not going to be trying to really teach them anything. And they also have active range of motion of both upper and lower extremities, and they do very well with push and pull exercises, reciprocal movement patterns, and also rhythmic movement. So some things to remember when you're treating these patients. So if we go to the next slide, late stage treatment strategies, and just because of the way my brain works, as I go through a lot of the considerations, I'll be throwing in treatment ideas as I go along. So something to really remember with these patients is they are very fearful of movement and fearful of falling. So you're going to want to take it slow, allow extra time, and provide a lot of reassurance to your patients, a lot of tactile cues so that they know that they're safe. These are going to be the patients you're likely going to see the retropulsion when they rise from a chair, or you have them taking some steps backwards. So it's going to be really important to encourage anterior weight shifting during your treatments. I once had somebody describe to me that a patient that's fearful of falling, if I could imagine what it would be like to have someone grab me and throw me off the edge of a cliff, that somewhat describes what these patients feel when maybe a CNA who hasn't been properly trained to take care of them grabs them and goes to move them from one surface to the next. It's a very traumatic experience for them, and it can really develop behaviors or responses in them where they're fearful of anyone touching them. So it's really important that we're conscious of how fearful of movement that they are. They respond really well to counting 1, 2, 3. So this is a great strategy to use when you're doing transfer training. On the count of 3, we're going to stand up. 1, 2, 3, let's go. So that's something important to remember. There's certainly high risk for falls. They will spontaneously stand, climb over bed rails, and sometimes bend at their waist to pick things up off the floor from their wheelchairs. So these are going to be your patients that are falling out of bed. Perhaps they've tried to spontaneously stand from their wheelchair and have had a fall that way, or they're bending over to pick something up off the floor from their wheelchair and they come straight out of their wheelchair. So be sure that you're looking at these patients in their environment and that we're modifying their environment to help reduce their falls. Maybe they need anti-rollback mechanisms on their wheelchair or some anti-skid strips somewhere where they frequently try to stand and self-transfer. Those would be some good strategies that can all be used in decreasing their risk for falls. Of course, these patients, they're going to be a high risk for wounds. They're not going to move around a whole lot without somebody guiding them. They will have their spontaneous movements and everything. So something to consider would maybe be implementing an up-down schedule, making sure that they're not laying in bed for 8 hours straight or sitting up in the wheelchair all day without changing positions, or at least pressure relieving, providing them with some pressure relief. They're also very high risk for weight loss. So it takes these patients 2 to 3 times longer to eat. They may be spitting their food back out. These are the patients, you're going to see them, they kind of spontaneously eat and drink on the go. They tend to do a lot better with finger foods or pre-cut foods. So they're going to be excellent candidates for restorative dining programs. If you have a patient out there that's struggling with weight loss, maybe that patient's going to be a really good candidate for olfactory stimulation. So do you know what their favorite food is? Do you know what's really going to get their salivatory glands going and get them hungry prior to eating? And if you did some good patient interviews and family and caregiver interviews, you'll be able to identify how to best treat this patient and reduce their risk of losing more and more weight. I know from personal experience, these patients do really well in a dining room where they're surrounded by other people eating. They have that visual stimulation that it's time to eat. When COVID hit, I can't tell you the number of patients that were referred to therapy for weight loss because everyone was isolated and eating in their rooms by themselves. So make sure that these patients are eating in an appropriate setting, that they're getting that visual stimulation and hopefully the olfactory stimulation and the cues that they need so that they're getting adequate nutrition and adequate hydration. These also are patients who are really at a risk for contractures. You know, they're not moving around a lot. They can easily become stiff and rigid. So they're likely going to require continual monitoring of posture, joint mobility, and soft tissue flexibility. This makes them great candidates for skilled maintenance programs. So these are the patients where therapists are really going to be needing to observe them on a regular basis to make sure that they're not getting too stiff and developing contractures. So what's their wheelchair positioning look like? That's another thing to look at with these patients. Do they have a neutral pelvis, or do they have equal weight distribution through their hips? Do they have that, you know, that standard 90-90-90 hip knee ankle position, or do they need some stretching and strengthening to correct these underlying deficits that we're seeing? How's their upper body look? Do they have that classic forward head and protracted shoulders and would benefit from OT working on postural re-education? Or do they truly just need modifications to their current seating system? A lot of times, and it's very unfortunate, they'll be referred to therapy because they don't look so great in their wheelchair, and therapy will maybe just try to modify the seating system instead of really diving in and trying to fix those underlying deficits. Now, again, we already talked about the patients. They're really not aware of too many things below their knees. Behaviors. So, and I know Becky and I talked about this. We don't really like to call them behaviors, but if you're seeing a change in your patient, if you're seeing fidgeting, yelling out, maybe them trying to repeatedly to get up out of a chair, that is probably them reaching out to us because they have a need. Maybe they need to go to the bathroom. Maybe they're in pain because they've been sitting there for so long. So really make sure that you're observing these patients and that you're looking at these, how they're reacting to their environment, or you know, what kind of behaviors you're seeing, and that we're really trying to meet the needs of our patients. Try to find out what's going on with that patient and how we can help. These patients, they respond great to tactile cues, gestures, visual stimulus. A lot of times you'll notice that these patients will demonstrate the death grip. So once they get hold of something, they really don't want to let it go. So this is something to keep in mind when you're doing transfer training. Maybe you're not going to want the patient to try to push themselves up from the chair. You're maybe going to want to give them a grab bar that's stabilized or a walker that's stabilized that they can grip and they can stand. And that way you're not trying to get their fingers to come out from around the armrests of the chair. It's also important to remember that training their caregivers that these patients have this particular behavior. So caregivers, you know, they have to help these patients with hygiene and changing and getting dressed, and maybe that patient's grabbing onto the caregiver and squeezing a little too tight. So educating our caregivers that you can teach a patient a self-hug, or you can maybe put something that they like to hold in their hand while the caregiver is trying to do some clothing with that patient or hygiene with that patient. So caregiver training is going to be a priority with these patients. We need to make sure that we're having lots and lots of communication between therapy, nursing staff, family members, as to what works best for these patients and to what strategies we can put in place to minimize negative responses when they're having interaction with their caregivers. And again, I know for physical therapy, one of our most common goals for these patients is simply to keep them off of mechanical lifts. So we do have a lot of these patients who are in the late stages of dementia on skilled maintenance, where we're doing continuous observation and adjustments to their treatments, just so they are maintaining their ability to transfer with limited assistance. So just to go over to the treatment ideas, functional and transitional movement. I think it's really important when you're doing any movement with these patients that we make it meaningful. You're going to get a much better response. If the patient is engaged and has interest in doing it, they're going to be more active and participate a little bit more in that. So for example, you know, let's get up and go to the bathroom, or let's go look outside, let's get up out of bed and go eat breakfast. So anything that's meaningful. You see some treatment ideas there, such as dancing, Tai Chi, scarf to the music. Again, these are rhythmic motions. These patients tend to love to do these things. So implementing those into your treatment using their favorite type of music, you'll start to notice that they'll start to dance in their wheelchairs, and it's actually quite fun to watch. And you can actually stand there and dance with them, and they seem to love that. We talked a bit about the implementing the up-down schedule if you have a patient who's high risk for wounds. We talked a bit about wheelchair positioning. So wheelchair propulsion, these patients are going to be very active. Locomotion is going to be their primary means of getting around. They seem to do very well with peer modeling with locomotion. So I tend to have a lot of success if I get a group of them together. I might take a little bit higher late stage patient and I will deem them my leader, and we follow the leader, and we do it throughout the building, we do it through the therapy gym, and they are just very successful and have tons of fun doing it. So really consider some treatment ideas, maybe getting groups together and the peer modeling, and maybe even, you know, locomotion to and from the dining room with the wheelchair is a good functional maintenance program to implement. With regards to meal setup, again, I talked about that finger foods and cut foods are probably best for these patients. Maybe consider only having their cup half full, because a full cup is going to probably have, you know, some spills here and there, and we want to avoid that. Hand over hand initiation of self-feeding is a really good idea with these patients. And again, putting these patients in a restorative dining program and making sure that the caregivers have the instruction and the training that they need to be successful with these patients. Setting up functional maintenance programs for standing and walking, so walk to dine. I don't do a whole lot of standing balance with these patients. You know, a lot of them require some assistance, but balloon volleyball, perhaps sitting, is an excellent group idea. We do that where I work, and the patients have a ton of fun. And one of the really rewarding things about working with this group of patients is they will surprise you. Leaders will emerge that you didn't think were leaders. Competitive. We have some patients that they're very quiet, and you wouldn't realize how competitive they are until you get them in balloon volleyball, and then they're wanting to just crush it. So it's just really rewarding to watch them open up and come out of some shells. Placing objects into target areas. So hanging clothes in a closet or putting items away in a cupboard or drawer. But again, make sure that this is something that's meaningful to the patient, something that they enjoy doing. You'll be much more successful if you do that. Sensory activities, so any fidgets that they can use, music, so the auditory stimulation, applying lotions for your tactile stimulation. I can't emphasize enough how well they respond to sensory stimulation of all kinds. So really make sure that you integrate that into your treatment ideas as well. I don't really want to leave speech out here. So communication strategies, these patients, they love to sing. They do recognize their favorite people and things. Again, Becky touched on that, yes, no questions are probably better for these patients. You don't want to ask them an open-ended question, just yes, no questions. You'll get more accurate responses. They can tell you what's comfortable and uncomfortable, so keep that in mind. And they are able to name by class or category. So keeping that in mind too. So just in summary then, it's really critical to determine at least an approximate cognitive level to set appropriate goals. Determining early, middle, or late stage will allow you to modify your approach according to their cognitive level and cater therapy around their interests. The more you know about your patient, the more successful you'll be. Be sure to document your findings that lead to your decision making. And remember, fit into their world. Don't fit the patient into your world. If you do all these things, you'll see a decline in patient escalated moods and an overall improved quality of living.
Okay, a couple of things in closing. I'm going to leave you guys all muted, but feel free to put any questions you have in the chat. And a couple of housekeeping reminders before we start answering any questions in the chat box. Don't forget, if you shared your computer with someone else, be sure to enter your name and your email address in the chat box. That way we can give you credit for your CEU. Please expect about a week or more to get your certificate emailed to you. We have quite a few people on this call.
Barb, we don't need everyone's emails. Just if they are sitting with someone else that is not registered. If they are registered for the course, then we have an attendee report that we can pull and we know that they're on. If they are sitting with someone else at someone else's computer, if there's 2 or 3 of them, that's when we would need their email.
Yes, only if you're sharing a computer. Yes, exactly. Now, for speech therapist, if you are a speech therapist, only speech therapists need to fill out the bubble ASHA sheets. So that there are 3 things attached inside your webinar here for you. There are handouts, there's the survey for you, and there is the ASHA bubble sheets in the attachments here. So the bubble sheet is only for a speech language pathologist, all right? Only those that are registering for ASHA. Keep in mind, there's a lot of people on this call, so give poor Shyla a little bit of time to get the certificates out to everyone. Another thing that I just wanted to finish up with is if you have questions, please put them in the chat box. Now, if you are a speech therapist, send your bubble sheets to Shyla Hamrick at aegistherapies.com. So on the screen there is the address. And please be reminded that we need this within 7 days. There is a very small window to get it to ASHA. So if you could fill it out right away and send it to Shyla Hamrick at aegistherapies.com. I also have in here some resources for you that I think are really good. Here is some resources for the cognitive assessments that we talked about. I also have some videos that I'm really big on videos. You know, if I see them, I can understand them. So there is a late stage video with treatment that I think you will absolutely love. It shows before and after treatment. There is a middle stage video that you can watch, and there's an early stage video. So again, those are some additional resources for you that are attached. Now I'm going to put you back on the screen for Shyla's. If you are a speech therapist, please fill out the ASHA bubble form that is inside the webinar. That's attachment, and please send it to Shyla Hamrick. Don't forget, please submit your surveys at the end of the webinar. It really helps us to know what's appreciated, what's not appreciated, what works, what doesn't work for you. Please fill that in as well. And that is also in the attachments for you. So with that,
we do have some questions, Becky. If everyone wants to stay, they can for the questions. If you want to hop off, you're certainly not required to stay, and you will still get your credit as long as you were on for 45 minutes of the call.
All right, thank you all. So we'll answer some questions now. Shyla, what's the questions? I'm not seeing them.
Okay, one is, would you provide a link to the My Way assessment? My Google search hasn't turned up for what you described. Thank you.
Oh, yes, I did include that in the very end. So there is the direct link to My Way.
Okay, and just to be clear, that's in one of the handouts. It's the, let's see, what is it called?
Right here, it's called
handout.
My Way, right here. Right here's the link for it.
Perfect. All right. Are there more cognitive assessments that are geared more for the SLP?
Absolutely. Now, I'm an OT, but I will tell you, there's the CQLT, which is a quick cognitive assessment. There is the ABCD, which is a lengthier and quite costly. There is the RIPA-G or RIPA-G, whichever. That is another one that's also quite expensive, and it's quite lengthy. There is, of course, the SLUMS, which is a screening tool. There's the mini mental, but that one you have to be paying for. There's the MOCA, which is, there again, is a screening tool. But I think most therapists really utilize the CQLT, and the BIMS is another one that's really common in MDSs. Does anyone else have any other cognitive assessments that you use for speech? You can type it in the chat box.
Okay. You said late stage dementia persons don't respond well to cut up food. Just clarification.
No, what I said was late stage dementia patients respond well to finger foods and cut foods.
It's hard to use utensils. It's hard to use utensils. So if you have to cut food, it's 2 utensils. And so it's a little bit more difficult. So
Yeah,
hopefully we answered that question.
Yeah, and I want to clarify that. So they would be pre-cut foods that the patients respond well to, you know, not cutting their own foods. So they respond well to finger foods that they can, you know, grasp, and they respond well to pre-cut foods that are on their tray.
Okay. All right. Ideas for a late stage patient who has limited vision.
Okay, so this is probably going to be,
question.
it is a good question, yeah.
Yeah.
So you're not going to be using any visual stimulation with them. You're going to be using a lot of tactile stimulation, a lot of hand over hand, and really going back to functional movement. So pulleys, you know, you're going to be placing their hands in pulleys. So for the upper body, that might be a good activity or a treatment idea, or the bicycle, if that's an appropriate exercise for them. Sitting on the edge of a mat table with making sure that they know that someone's right next to them, for some core stabilization. So those would be some things that I would use. Becky, can you think of anything?
Lots of sensories. Yep. I would really focus on your sensory and your transitional movements that are rote from your procedural memory, like transfers, getting up out of bed.
And don't forget about, you know, the auditory stimulation, where you can stimulate them using songs and things like that, where they're going to do those rhythmic movements on their own then in the wheelchair, or even sitting unsupported, as long as they're safe.
All right. Let's see. Any resources for new or great pharmaceutical treatments to slow progression?
Ooh, that's a good question. I'm not really good with pharmaceutical approaches, so I beg to stay away from that one. I don't know enough to give an educated amount. I apologize. Barb, do you?
No, and I agree with you on that one, Becky. I think that would be a lot of collaboration with your medical director or your nurse practitioner.
My philosophy is always use therapeutic approaches first. So, sorry.
Okay. How to determine when home assistance is needed and how much per day?
I love that question. That is such a big, powerful question. 4.8 or above on the cognitive level is usually when you can be home alone with some supervision, periodic supervision, like setting up medication box, making sure you're not being scammed by the bank or by scammers. I would say 4.8 or above, they could live alone. Anything below, I'm sorry, 4.6 or above. I'm sorry, I said 4.8, but 4.6 or above would be good for living alone. Below that, then 4.0 to a 4.6 is good for assisted living.
All right. Let's see here. Have you had issues with getting therapy covered by insurance for maintenance therapy for these patients? Can you give examples of goals for maintenance therapy?
Yes, that's a really good question. Skilled maintenance is more a goal to maintain transfers without having to go to a Hoyer, might be one examples that Barb was talking about. So an example might be your late stage dementia, someone that has Parkinson's, maybe someone that has ALS. MS is a tough one because they're variable from day to day. So anyone that is different from moment to moment, day to day, minute by minute are really good for skilled maintenance, because if we were not seeing them, they would be transitioned to a Hoyer, or they would be transitioned to a program that might be conducive to furthering their decline. So an example for PT might be for them to maintain their transfers. So I might have a goal that patient will maintain transfers or maintain a Berg score of a certain level to avoid having to transition to a mechanical lift. Patient will maintain minus 70 degrees of contracture. So that patient will be able to sit up in a wheelchair, that type of thing.
All right. Let's see. In a SNF setting, do you recommend SLPs screen patients suffering from dementia quarterly?
That's a good question. I recommend screens on every patient in a SNF quarterly. That's what Medicare requires, and that is what the omnibus requires. So that is a definitely. I would require a screen. Now, whether I pick them up is a different story. If there's a decline or a change of condition, then I would evaluate and pick them up. But definitely at least screen every quarter. Barb, do you want to add anything to that?
I completely agree with that. CMS expects us to screen patients quarterly for all disciplines. And if that patient triggers, even with a fall or a altered mental status, you might need to be getting in there even more frequently than quarterly. And I know that in our skilled nursing facility, we encourage the SLPs to do a full assessment on a yearly basis once we've established a baseline cognitive level, so that we know how that patient's changing and how we can better manage those patients' needs. And we also communicate a lot with those patients' caregivers if we're noticing any changes or declines. So, and like you said, Becky, a screen, yes. A full assessment, no, not on a quarterly basis, but definitely if there's an indicator for a full assessment.
I'm seeing a lot asking about the survey. It's not in the handouts. It will be launched after the conclusion of this webinar, but it will also be emailed to everyone with the registration email that you gave. So no, it's not in the handouts, but you will get it.
Oh, I must have misspoke. I apologize. Thank you for clarifying that, Shyla.
No problem. And then will you all have more of these sessions to receive CEUs? The answer is yes. We have one monthly. Be on the lookout. We have them, if you're internal, we have multiple emails that go out. I'm not sure. I think it goes out on Phenom, maybe LinkedIn. I'm not sure of the other resources, but yes, be on the lookout. However you found out this one, we do have one monthly. What are the restorative exercises do you advise for dementia patients?
Good question. Barb, is that something that, since you're the expert on exercises?
Yeah, I think it depends on what stage of that you're looking at, because that's going to vary significantly depending on the stage of the patient. For your late stage patients, our restorative programs include locomotion to and from the dining rooms, possibly with the wheelchair if that patient doesn't do well with walking, or walk to dine if they are pretty good at walking with assistance, and the CNAs can show us that they can do it safely with those patients. We utilize upper and lower body bikes a lot. It's a very functional movement. And so they'll do cycling restorative programs, and that maintains their joint mobility and their soft tissue flexibility. Now, for middle stage patients, Becky, I'll let you kind of answer that one if you feel comfortable with it. But again, it's going to be based upon your patient and how they do during their therapy and what's most appropriate for them.
Yes, for your middle stages, yes, you definitely want to get them to expend energy. So bikes are really good. Your bikes, because they're reciprocal and they are methodical. So those are really good things to have in the area to expend energy. Closed chain activities or exercises are much better than open-ended exercises. and also things with pictures as opposed to words, of course. And they're not going to do it unless somebody's there to tell them to do it. So functional things is your key, functional.
Can we rewatch the webinar recording? If you're internal, the answer is yes. Through our clinical field resources SharePoint, we have a folder called Impact with Aegis, and all of our recordings are there. You can't obtain CEUs for those, but they are there for informational purposes. What would be your reason for referral for eval on a yearly basis for SLP?
To assess decline or to reestablish baseline. Barb, do you have any other suggestions?
No, I agree with those. Again, we're going to be wanting to see what kind of changes are happening in these patients. And the only way to do that on a yearly basis is an evaluation that we're getting objective measures and we're retesting. And, we really need to know how to best meet the needs of these patients. And they may
These
have
are
had
very high risk. Mm-hmm.
Yes, they are. And we need to know if they've had a decline, especially if you're working in a facility that has an implemented dementia program throughout the facility, such as red light, yellow light, green light. If that patient changes from a middle to a late stage, we're going to want to know that. We're going to want to change how we interact with that patient.
Does the 4.6 come from the Allen levels?
Yes.
Okay. Can the OTR do cognitive assessments? If so, which cognitive assessments do you recommend?
OTs and CODAs can do cognitive assessments. Actually, anyone, PT, speech, anyone that has been trained and has demonstrated proficiency in the cognitive assessments. Now, the OTRs are the only ones that can interpret if a CODA performs it. So if there is a level 4.6, the CODA can indicate that the patient is a 4.6, but the OTR has to come in and interpret what a 4.6 means.
Okay. Regarding olfactory stimulation, what would you recommend for patients when there is limited food options within the facility, and could you provide some examples of ideas for sensory stimulation options?
Yes. So even if you have limited food available in the facility, one of the things that I've done in a facility that I've worked in the past is we've brought a bread maker in, and we will make bread in the morning, or we will make bread in the late morning. And the smell will permeate throughout the therapy gym and in the dining room if that's where you decide you're going to make it. It's safe, and it doesn't have to be even just bread cooking. So if you can't use something that, that patient is one of their favorite things, a great example is a bread maker, and I've seen it used in multiple facilities. And a lot of times, once the bread's done, we'll even bring groups of patients down and have bread and butter or bread and jam with coffee. And it's just a really good example of how you can use the stimulating the sense of smell. Some other examples of sensory stimulation, you have the auditory stimulation where you're using music, or perhaps I have certain patients that like Frank Sinatra, and then I have patients that love Bach. So really getting to know what's your patient's favorite song or type of music is really important as to how successful you're going to be when you use that auditory stimulation. Tactile stimulation, I do a lot of thoracic massage with my patients. It not only just is hands-on with them, but it also increases circulation. And there's some research out there that's increased circulation to the thoracic spine actually enhances cognition a little bit. Becky, can you think of?
The smell of roses can increase the vitals. I've seen just the smell of roses might make someone turn their head, visual tracking, a smile, even eye contact. By just smelling a rose, you will see the vitals go improve.
And I mean, wax burners are safe. There's no open flame, and there are a ton of different smells for wax burners now. So,
What type of treatment is beneficial when a patient with dementia screams all the time? We often ask if he's having pain, hungry, etc.
That's a really good question. It's a very common thing. It's almost like taking care of a pet, a cat or a dog that's hurting. It comes out in a behavior it comes out in a need. So they have a need, and really what we need to do is figure it out. We have to play, we have to imagine that, okay, this is an infant crying. Okay, so are they cold? Are they hot? Are they have been sitting in one place? Are they bored? Are they hungry? We have to go through that full gamut as if they were an infant to determine why that patient is screaming. And it becomes a habit, really. It really becomes just a vocal soothing noise for them to be screaming out, unfortunately. So I have noticed that it takes time for that to taper down, but it's a matter of asking the 20 questions as if it were an infant.
Do you screen for depression as a contributor for dementia?
Every single one of my patients.
All right. What is proper way to release the tight grip for late stage dementia?
Putting something in their hand, they have the death grip. And so putting a brush or a bottle of water or something in their hand so they don't squeeze you. So they're grabbing something else instead. Putting their hand to the place that you're going to. So if they're going to a walker, usually we put the hands on the wheelchair if we're standing, but sometimes it works better to put the hand on the walker before they stand up. One hand on the walker, one hand on the wheelchair. Also, putting the wrist in extension. I know this sounds kind of crazy, but if you put the wrist in as much extension as comfortable, it will open up the hands.
Okay. Once you identify depression, what do you do differently in RX?
That is a really good question. For me, it is a matter of knowing that they might need more socialization. They might need to get out of their room. It's important for me to know the difference between dementia and depression. Dementia is really where they try to do things, but they can't. Whereas depression is they don't even want to try. So there is a difference between dementia and depression. So it helps us, if we know that they have dementia, then we're going to focus more on making them feel good and making them feel valued. The self-hugs are important. Physical contact is important. Getting out of the room, the socialization, all those things for depression are really key. And I really think that depression and dementia often go hand in hand.
Is there a well-established or recognized dementia training program for therapists?
Oh, that's a good question. A well-established dementia program. Not quite sure how to answer that. I don't know that there is necessarily a defined program. There are different programs that are set up in the facility, such as the red, yellow, green program. There are dementia care specialists that really work with identifying levels and programs. There is the TIPA Snow that uses emeralds or different stones that represent the cognitive levels. and they are represented by a stone. Trying to think of what else. Definitely the Allen Cognitive Network. I love the Allen level. I think it really helps us define the patient's performance and then to modify the approach according to that level. So some things to really search into, I think, is the TIPA Snow that really looks at GEMS, and also with red, yellow, green programs. Of course, I don't know if that's a standardized program, but definitely dementia care specialist as well. I muddled my way through that one. I had to think. Thanks, Shannon.
How do we get Medicare to continue maintenance therapy opposed to higher level costly care?
It is a program that really allows cost-effective approaches. For example, if we have a patient that goes on caseload, off caseload, back on caseload again, we rehab them, we send them back, that is not a very cost-effective, and that is a reactive approach. But a skilled maintenance is a Medicare B benefit that the patient has, and provided we do good documentation and we support that it requires the skills of a therapist to maintain someone's ability, then it is a benefit to the patient.
All right. One of the biggest struggles in the facility I work in is getting staff to consistently carry over FMPs, especially with feeding. Do you have any tips to help with consistency and carryover?
Over and over and over and over. Remember, it takes 3 weeks to develop a new pattern. And so I would say keep at it, keep at it, keep at it, keep at it. That is the biggest thing I can say.
And I agree with you on that, Becky. You know, I work in a skilled nursing facility and I know the struggles that you're talking about. And what works best for me is that continuous, ongoing caregiver education, almost where I'm kind of in front of them all the time. And they see, I will actually implement the strategy directly in front of the CNA and the nurse, and they'll see how successful it is. And over time, they will realize it's going to make their job easier. I guess that's the best advice I can give you if you're struggling with, you know, staff carryover with your programs. Is it's just a continuous effort, and it's okay for you to continue to educate them if that's what the patient needs. So don't be I know a lot of time as therapists where, well, is Medicare going to pay for this? If your documentation's there, it's justified. If it's what the patient needs, it's justified.
Okay. Is there any way to get the sensory motor assessment you talked about?
It's an Aegis product, so join Aegis. There are probably other similar assessments out there. I just have not found them as good as the SMA.
All right, guys. Well, that wraps up our questions.
All right. Thank you all.
Thank you, guys.
Thank you, Shyla. Thank you,
problem.
Shannon. Thank you, Barb.
Thank you, Becky. Bye.